The surgeon and the electrophysiologist, they're still in the OR. They are really trying for the last line to be closed, so they will not return on time, which is a pity. Patient is doing well, still in sinus rhythm, but Laurent, supported by Mark, are still trying to finish it completely, and I hope they will stop before 6. So it's very unfortunate, but we are at present not going to show the video cases because that's their show. We cannot applaud also for them because they will be late. So I'd like to close the session. I'll try to give a wrap-up shortly. And one thing to say here today is that we can still learn a lot of the biology of atrial fibrillation. It has been told repeatedly that you can find AF on the ECG very easily, and that's a big problem, in fact, because then you are just focused on this ECG, and if the AF stops by itself, we call it paroxysmal, and if it doesn't stop by itself, we call it persistent. If it's over 1 year, it's long-standing persistent. And that's what Joe Tayano explained very easily. Well, let me have a look under the hood. That's what you're saying. So we have to think more scene of calamity. So we should look at the site where the problem is, which is the atrial wall. It's this thin vessel wall. The ventricle is hanging at it, so it's a funny structure which has this strong left ventricle, which is there floating freely, and the atria, they just have to attach it to the back of the body where the pulmonary veins are, and they really keep the atria there in place. And looking at a scene of calamity may become very more and more important in the future, and have you seen the MRI images, and they will improve in the future. And there's lots of opportunities also with scintigraphic techniques, probably. Also, echocardiography isn't finished at all in this respect. And I think presentations yesterday learned us that there's a lot to learn there. And we should move a little more towards the diagnostic side before jumping on all these nice therapeutic options, which are okay. I think it moves the business, but it's also important to look at the diagnosis. And we also heard today especially, and Ralph Damiano and Carina Blumstrom talking about surgical ablation especially. They focused on items like transmurality. Transmurality is really key if you want to be successful. And the key of the interventions we do for AF is, especially for a surgeon, that's the posterior left atrium. That's again a funny structure where a lot of arrhythmogenicity from various levels resides. And if you do not exclude that, then after with your procedure, then you probably are the patient may have a problem, and that's also apparent from this recent New England Journal paper from the Cardiothoracic Surgical Network, where you in fact see that the 1 year arrhythmia-free survival is I would say only 65% with what they call a full maze. And that's about transmurality again, and taking out the posterior left atrium. If you don't do that, then you will have lower percentages of success. And the next point to talk about here in the summary is on cryoballoon. We had a very nice presentation on first and second generation, and that's really a one approach fits all approach. And I think that should be used cautiously, obviously, because it's a very powerful tool. That's what Giambattista Chierchia showed us. And then we had a presentation on the reversed hybrid. You know, Joe Tiano and the surgeon, they do this very nice approach where they at ease do first the catheter ablation and then next day do the surgical ablation, and that really fits together. And that's really the a very nice example of how surgeons and electrophysiologists, cardiologists can work together. Another important point is on anti-thrombotic treatment. We did not touch too much on it. Gerd gave, standing on that microphone, a very nice summary of whether or not to close the appendix, and I think you had very valuable comments. So think twice before you close it. In fact, that's the bottom line, and beware that we are not very sure about how safe it is and how effective it is, and we do not know really in which patient it's going to be a benefit, because strokes do not emerge in pitch with atrial fibrillation only from the left atrial appendix. They may emerge from several sites in the cardiovascular system which approaches the brain. And another important point where we have not yet an answer is when to stop anticoagulation after an ablation. But the general rule should be, I think, don't be too optimistic on stopping anticoagulation, and don't promise your patient that you're going to stop it anyway after the ablation. Because if you can't promise it, then the patient didn't have an indication anyway, because those are the patients who are CHETS, VASC score 0 and 1. They don't need anticoagulation usually, and those are the ones, exactly the ones in whom the ablation, also the simple ablations, they are effective. So you got sinus rhythm and you didn't have an indication for anticoagulation anyway. So in the other patients, so the higher risk patients, they have a risk of a recurrence. So the stroke risk and the recurrence risk, they go hand in hand. So the book hasn't closed at all on one hand, efficacy of all the interventions we do have for AF, so getting rid of the AF. It may happen also in the higher risk for recurrence patients, but that's not the same as saying that your stroke risk went away because you simply took out the atrial fibrillation. But because again, atrial fibrillation may just be a marker of a vascular system which is much more vulnerable to remodeling, thrombogenic remodeling, and so even without having AF near a stroke, you may have a stroke, which appeared from, for instance, the ASSERT study. And then, I can conclude how somehow talking, I'm not going to repeat the flamboyant presentation by Gerd, which we know very well. The way he presents, all want to know about catheter ablation. But the lessons I took there is that, when it's about ablation, we are especially talking about improving quality of life. And the reverse of that is taking in patients for ablation who are symptomatic, rather than patients in whom you think you can take away the atrial fibrillation. If the atrial fibrillation doesn't have a meaning in terms of symptoms and quality of life, then there is not too much to gain. And if you are comparing studies, and that was really an eye-opener today again, then you have to make a fair comparison. So when eventually the Mantra PAF study came out, then we had a good comparison of drug treatment versus catheter ablation. And then, obviously, catheter ablation does okay, and we can be content with that. But most of these patients need antiarrhythmic drugs anyway. And I think my personal view on this item is, yes, we need to develop on interventional cardiology here, so ablation needs to be improved. We need to work with the surgeons together to improve, but we should not lose our competencies in the area of anti-arrhythmic drug treatment. And that's something we as leaders in the field, looking at myself, I'm still leading for some years the field, we have forgotten maybe a little on the anti-arrhythmic drug approach towards atrial fibrillation and arrhythmias in general, and that needs to be brushed up and made much more alive than it's now. And on the rotors, don't look for the rotors. That's what I understood, Gerd. And you know, even there is much more to learn, because the end is not yet there. We haven't seen the end of the rotor business yet. I would like to finish now by, first of all, thanking the sponsors, which are on this slide: Atricure, Philips, Bayer Healthcare, our research school, Crijns, sponsored by Science Webster, and Medtronic. The other point I want you to take again from this slide, Jos Maassen introduced us yesterday to the course. There are 6 bridges here, and I'm not saying surgeons to the right and EP to the left, but what I've seen here is much more than 6 bridges today and yesterday. Much more than 6 bridges. There were lots of people talking to each other, enthusiastic, sharing ideas, trying to put up new, generate new ideas and learn from each other. Not only surgeons and cardiologists, but also technicians and people from industry, fellows, PhD students, and so on. So I was very happy with that, especially also yesterday night, where we had a very lively discussion over 2 patients. And I really want to thank you all for hanging in there and coming up with all the comments and ideas and notions and all the liveliness. And now I want to thank 2 people in particular, and that's the ladies in the back. I don't have the flowers, that's Lisette and Monique. Maybe you can really stand up, both of you. Because, ladies and gentlemen, these 2 guys, I would say, it's 2 girls, they took us on this path and kept us on the track. The only point they didn't have on the track was the surgeon and the ablationist. They are still in the OR. But that's something for next time. I really want to thank both of you, Lisette especially. You have supported the course very well, and you have been a link to everybody. And I will send the flowers tomorrow because you didn't keep me on track with the flowers. So that's the point now. I hope you enjoyed. I also hope that you will come back to the course, to future courses. And with that, I'd like to close and thank you all for attending.